can see that patients have a lot of difficulty in daily life and in independence in their daily life. So the upper limb function is really close to autonomy and quality of life. So just to introduce the specific basic on neurophysiological point of view. So we know now that vision and movement are really closely linked. And in the brain, we can identify some specific neurons dedicated to vision, but also to movement execution. We have two kinds of neurons. The first one is mirror neurons. So these neurons is involving in recognizing movement executing by someone else. So that means if you are looking at an action performing by someone else, in your brain, you will develop a part of this motor program like you will produce the action. And the second part of the neurons are canonical neurons, and it's linked with the recognition of familiar object. That means when you see, for example, a mobile phone, a glass, a spoon, or something like this, just seeing the object, you will promote automatically in your brain part of the motor program to reach, grasp, and handle the object. Just to explain in more details how it works, we can see here a specific research from Murata, and you will work with some apes, and we will introduce some needles in the brain for the apes. And the setup is to present a box.
Sorry, Davy. Sorry.
Yes.
I don't think your PowerPoint is working. We can't see. You didn't move the PowerPoint. You're still on the first page.
Yes? Okay.
Yeah. I'm sorry about that, to interrupt you.
Oh, no. I'm sorry too. Excuse me. I will try in that way. Is it moving now?
Yes, it is now.
Yes, it's working now.
Okay. So excuse me for the trouble. So just here we have the neurophysiological basis as I presented to you, and here the specific research program for Murata. Here, and what is interesting, excuse me, here. So here we have a specific setup with monkey sitting in a chair with a harness in order to not move. And we will present to these monkeys a box with a specific handle. And then we will try to organize something to let the ape try to grasp the handle, open the box in order to take what is inside the box. And we will make a specific focus in 2 points. So line A and B here. And sorry, here you will have the specific results on. On the first line, you have V and A and M, means visual and motor cortical area. So it's a specific part of the brain dedicated to vision and also action. And you will have 2 lanes, 2 specific conditions. A with a familiar object. You can see here the handle and the type of grasping for the monkey. And on lane B, you will have a specific precise grasping with the thumb position. So on lane B, what is interesting is this kind of grasping is not really used with monkey, and it's not on the motor pattern of monkeys. If we are going back to the lane A, on the first situation, the first graph, you can see manipulation in light, and you have vision and action specific steps. So on the first part of the graph, vision, you can see that only seeing the box and the handle is enough to start to recruit this cortical area. And when we ask the monkey to perform the action and to go and grasp the handle, you can see also that you will have some brain activation like vision. So here, in this specific part of the brain, you can see that vision and action is really linked, and you have the same cortical activation in both moments. If we are moving to the manipulation in dark, the second graph, you can imagine that if we are performing the action with less light, so in darkness, vision will be less effective. So the first part in vision is less recruiting the brain area, but still, if you perform the action, if the monkey is performing the action, you still have brain cortical activations. And the last situation with object fixations, that means the authors remove the box far from the monkey. So the monkey is just able to see the box and the handle, but it cannot reach and grasp the handle because it's too far. But what is interesting here also is to see that just vision, it's enough to create a cortical activation, even if you have no potential of action behind. So this is the normal brain activation if you know how to planify and how to grasp the object or the handle here. The second line, line B, here, the first graph in light, you can see that because the monkey is not very familiar with this kind of grasping, vision doesn't create any cortical activation. But if the monkey is trying to reach and grasp, you will have the brain activation. So this graph is very important because you can see here if the monkey and then if human or patient don't know how to produce, how to imagine the movement, you will have less cortical activation in that part of the brain. And the main objective for us will be to promote rehabilitation, to teach again how to imagine, how to planify the action in order to switch from the B line to the A line in order to prepare the action before moving. So if we have to summarize this part, we have three main pillars in motor control principle. The first one is body awareness. It's very important for patient, for human, to pay attention to the body awareness, body consciousness, and to consider the body before to move. And then on the strict action or strict movement production, you will have two parts. First part will be the action planning. So you have to prepare your action, and then motor execution in order to recruit muscle and to execute the actions. And if you go deeper, once again, on more details on the two steps, action planning, first of all, you have to see your environment, to perceive some object around you, to create some potential of action. And then regarding your interest, you will try to develop the motor planification and intention to move. Thanks your intention to move and your start, you will recruit muscles, execute the motor command, and collect some feedback in order to control your movement. And what is really interesting is to see that for people after stroke, but also in other kind of pathology, if you have pain or complex trauma, we can see that action planning, so the first part of movement, is quickly altered and sometimes non-existent. So we have a lot of evidence now on literature to see that if you have stroke, for example, you will have some body awareness disorders, some decrease in your ability to produce the mental imagery and the mental planification of your action. You will be less effective in creating motor commands and to control your movement during the action. So it's really important to keep in mind that in movement production, you will have two steps, action planning and motor execution. So for rehabilitation perspective, we have to work also on both sides. Just to let you see some parts here on immobilization protocol. So in healthy people here on the left side on NGOMO studies, we will have some evidence. And if you create some TMS stimulation to assess the motor command before splint and immobilization and after 4 days of immobilization, you can see now on literature, you will have some difference in your ability to create the motor command and your ability to create the motor command and to promote the right motor command to the muscles. So this part is affected after 4 days, for example. The right part is dedicated to motor control, and on the upper part here, you will have the control group. So you are in front of a table and you will ask volunteers, healthy people, to make some pointing task. So they have to point the two targets as fast as possible. On the first one here, you can see that you have a good pathway and low variability in movement production. If you look for the 6 hours movement production, you start to have some deformation about movement. But what is the main effect is after 12 hours, you will have bad movement production and movement control. So 12 hours is enough in healthy people to create some disability and impairment in movement control. And what is interesting on the bottom part, you can see the normal hand path area is much bigger after 12 hours, and also variability in hand pathway and variability in interjoint coordination. So both system is really combined, linked, and it's important to keep in mind that you have to work on mental planification in order to improve movement production also. So on motor planning, we spoke about the first part of action planning and motor execution, but in rehabilitation pathway, we have plenty of techniques to support movement production. We can use task-oriented therapy, CIMT, muscle strengthening, robot-assisted therapy, FES, etc., etc. So we used to have lots of techniques to support motor execution. But at the end, we have some few techniques to work on action planning. And action planning, we can say that you can work on action observation, motor imagery, or mirror therapy. Okay, you can use also other techniques like hypnosis, for example. But the problem is how often are you using this kind of techniques regarding your patient and also regarding the motor execution techniques? Here, we will see first the brain on the right part on motor performance and motor execution. If you are producing a bimanual movement, you will have a specific MRI assessment and specific brain activation. You can see both parts of the brain is recruiting in the motor cortex area and also the bottom part of the brain for the visual area. Now, so this is the main profile of cortical activation. But if we move to the observation part on the left part of the slide, you can see that observation, so you will ask the volunteer to just observe someone performing the same action. And in observation, you will recruit the red and yellow part of the brain. The green part is the difference between observation and motor performance. So in observation, you will recruit only the red and yellow part. Now in the middle, if you are performing motor imagery on the same action, you will recruit the blue part and you won't recruit the red part, okay? But what is really interesting is if you superimpose the red and yellow part from the observation and the blue part for motor imagery, you can create quasi the totality of motor performance brain activation. So it's really interesting to see that even if you are not able to produce a movement, you can produce the same kind of cortical activation. And it's really interesting in terms of rehabilitation for patients, especially after stroke. And here, you will have a lot of evidence in literature on action observation, motor imagery, and mirror therapy. Here, this is a specific protocol in chronic patient after stroke. And this protocol is dedicated for upper limb rehabilitation, but especially they are trying to improve the drinking motion. First, you have the control group, so you will add specific amount of time with a classic rehabilitation. And then you will have 3 other intervention groups to work on specific techniques. The first one is observational training. So you will ask patients to just observe a video where you can see one other person performing drinking motion. Action execution is you will ask your patient to try to produce the movement. And then observation and execution, you will split the time in 2 parts. First, observation, you will ask the patient to observe the video, and then they will try to repeat. But at the end, to compare all the groups, you will have a specific dose control to really control the effect. First important point is if you are able to add some just observational training to your daily rehabilitation, in fact, if you can add some observational training to your daily process, you will have some positive effect on upper limb rehabilitation. So observational training would be higher than the normal and control group. And the second part is the main result is if you want to be the most effective, you have to create observation, then execution. So that means you will suggest to your patient to observe the principle and then try to reproduce the movement. So first to learn and to imagine the movement and then try to execute it in activity of daily life or in different conditions. And just to finish on that part of clinical evidence, we have the Pollock review in 2014. It's a Cochrane review where they are performing some review on the effectiveness of different techniques on upper limb rehabilitation, on upper limb function, upper limb impairments, and activity on daily life. So you can see on the upper parts here of the table. And then in the different column, you will have effectiveness or not. In mirror therapy and mental practice here, you can see that it should be very effective, even in chronic rehabilitation, but it's really effective techniques. So the question is, are we able to use it in daily practice? And finally, the main difficulty is to fill the gap between clinical evidence and practice. In our hospital, from our experience, so the clinical experience we had in the University of Saint Etienne, before to develop our new techniques, is we would like to use mirror therapy and motor imagery with our patients after stroke. But 70% of our patients were excluded of these techniques, especially because they have some limitation, like cognitive disorders, attention deficit, learning disabilities, etc. So it was very hard for us to really include and implement these techniques in our rehabilitation pathway. The other part, the neurophysiological part here, is to see that in mirror therapy, for example, you will use the healthy hand during movement. So in healthy people, if you are moving the left hand, you will recruit the right hemisphere. If you are moving the right hand, you will recruit the left hemisphere. And here in stroke patient, few days after stroke, in a patient with some impairments, if you ask him to move the affected side, you can see that few days after stroke, 2 days after stroke, you will have the same pattern with normal people. But because you are not able to use your hand, you will create some brain compensation, and step by step, you will develop bilateral activity. And probably this behavior will break the process of brain plasticity and will limit probably the upper limb rehabilitation and brain plasticity. One other thing is really interesting now in the second part of the graph here, the pictures, is if you have low impairments, very few impairments, this process is very enough effective. But if you are a severe patient, you can see that bilateral activation and compensation in the brain will be really much bigger. So we have to consider also that point and have a specific lateralized stimulation. So now in Ibs Presentation, here you can see the complete workstation of the system and with two screens. This screen, the lateral screen, is dedicated to the therapist in order to control the session, to program the session and to have some feedback on how it is going on. And the frontal screen is dedicated to the patient. It's a big and large screen in order to cover the hand and also to improve immersion for patient. Then you have some specific button to adapt the position of table, of screen, etc. The main principle on IBS-3. So first of all, you have to place the healthy part of the arm in order to record some specific movement regarding the pathology of your patient and your objective. And the patient is able to see the healthy hand on the screen. Then regarding this, you will ask the patient to perform some specific movement. The software will store and flip the video in order to create the opposite movement on your affected side. So the goal is really to let the patient see the hand is moving again and to decrease the mismatch between what they are trying to produce and the feedback they will receive. So we will try to restore a coherence between what the patient tried to do and what he perceived to prompt relearning process and to prompt engagement and motivation. So here you will see a video for a patient. So this is the first part of recording a movement. You can see here the patient is doing some specific movement on the healthy side. So pronosupination. Then you can place some object to help the patient to control movement and to have some specific and precise or accurate movement. So here to control the wrist extension and flexion. And then you can store. You can also demonstrate under the screen what you want to produce for your patient. So here, fingers dissociation, for example, the sequence. And then you can click on the button to record movement of patient. So here I will show into the screen the finger I want he will move. So you can also play with your patient to help him to produce the movement. And finally, here I will ask my patient to grab a very small pieces in order to improve dexterity and precise movement. And then also here you can see that I will ask him to move the object between all the fingers and work on fingers dissociation and then opposition. So the motricity for this person is very good on the affected side, and we would like to work really on precision and dexterity. If we are going deeper to the software, so we have specific option on software. First is some tutorials and video to help you as a therapist, as a doctor, to present the principle to your patient. So you have several videos inside to describe the protocol and to describe the main principle of brain plasticity, mirror therapy, action observation. You will have some specific assessment also dedicated to specific pathologies. So that means if you have a stroke patient, you will have specific evaluation. If you have CRPS or amputation, you will have also different kind of assessment. So it's really linked to the pathology of patient in order to help you to program the session. And then you will have some care program. So inside the software, you will have some algorithm to help you to create an adapted and personalized therapy thanks to 800 exercise. So here, because you have pathology, the first evaluation, and your objective of rehabilitation, the software is able to give you some recommendation. And then you will choose. And finally, you will have some activity reports to make some specific follow-up of your patient. Now, let's move to the clinical practice and guidelines. So the main pathology you can treat with IVS is for sure neurologic patient like stroke, brain injury, and cerebral palsy. So here you have a lot of evidence on literature to work on them, on that kind of patient. So you can also work with the device. You will have some specific protocol on orthopedics, polytrauma, CRPS, immobilization, amputation, then plexus, but also neurodegenerative disease like multiple sclerosis, for instance. And the inclusion criteria are very wide. The main advantage here is you will be able to adapt the stimulation to very different kind of patient. If you have cognitive disorders, attention deficit, aphasia, or bimanual impairment, it's very hard to include in protocol with mirror therapy, motor imagery, to develop autonomy, for example. So here, my suggestion is really to test the device, and you will have some tips and tricks to adapt the stimulation, to adapt the position of patient, to adapt video to this kind of patient, even if you have this kind of disorders and associated disorders. The basic model protocol, thanks to the literature, is mainly 1 or 2 sessions a day, 3 to 5 days a week, depending if you are working on acute rehabilitation in a chronic patient, depending your organization also, and mainly between 4 to 6 weeks. The normal average time per session is from 10 to 30 minutes, depending the tiredness, associated disorders, etc. So you have to adapt the duration of your session to your patient, and 4 to 6 different movements, sometimes a little bit more, with 6 to 10 repetitions per movement. And the goals is really to start with body image disorders. So you have to let time to your patient to pay attention to the hand, to consider once again their affected side. And then when you are making some progress on that part, you can focus on pain, spasticity, or motricity disorders. And if you want to be more precise, you can work on improving motor recovery, you can reduce central pain, you can reduce spasticity, you can work on hemi neglect, especially, or body awareness disorders. Now, let me show you a specific session with my patient. So here, as I told you, this patient is quite good in terms of motor recovery. And here you can place the screen really up to the natural position of the upper limb of the patient. And first, we will ask him just to observe, to let him the time to see the hand, to consider the hand, but also to deal with emotion. And then you can ask him, try to move. Oh, excuse me. So once again, first here, just observation, okay, to let him the time to imagine the movement, to recognize the movement, to planify it correctly, and to pay attention to the movement. And the second instruction will be, okay, now try to produce the movement with your hand in the same time. So I ask him to follow the video, and you can see that the coherence between the video and visual feedback and what he is producing is very good. So I start first with a simple movement to reinforce the immersion, and then after several repetitions, you can try to enlarge movement production, complexity, and to go deeper in your objective. So here I put my hand on his forearm also to limit the compensation. So here I can control the elbow position, and then I can force him to work with the wrist extension and then flexion. And you can see that I won't put the object on the table to not give him any feedback, bad feedback. Here we can move to video for fingers dissociation. And you can see that the video and movement production is very, very slow to force him to control the movement, but also for more impaired patients to let them the time to produce the movement. So slow motion when you are recording the movement is really, really important. And here you can see fingers dissociation behind the screen. So it's important to see what he's able to do behind the screen, but not to be only focused on that part, because you have also to consider participation, concentration, etc. Here, the last exercise, my main objective for him, you can see the grasping and then the movement with objects. So try to move the cube from one finger to one other. Keep the opposition and insist on fingers dissociation in order to really make the extension on other fingers. Maintain the position in order to force him to really make the dissociation with fingers. So his main difficulty is in daily life is really the fine dexterity movement. So that's why I force him on very complex movements. So you can work on patients with no motor recovery, really in acute stage, or with very impaired patient. But you can work also with chronic patient like here, with good motor ability, but still with some difficulty on daily life or some coordination disorders. And then what is really, really important is to try to reproduce what you are doing before in order to let him see what he is able to do. And this time with object. So try to force him to learn the movement with the IBS and then try to integrate with visual guidance. And here what is a bit funny was before the session, he said, okay, this movement, I will never be able to do it. And after, he said, okay, now I can do it. So it's very important. Now here, just to let you see also other kind of pathology, you can see spasticity treatment. It's a chronic patient, also more than 10 years of stroke with a huge amount of spasticity. It's around 3 points in a modified Ashworth scale in the wrist and also on biceps. So first of all, before to start, in order to fix your objective and also in order to fix the movement you will record, you have to test the patient in motricity, in pain, in sensitivity, in spasticity here, but also to speak with them about their main objective, to link your session and the visual feedback also to the objective of patient. So this person sometimes can feel pain on wrist. And during mobilization, he really feel pain when I try to stretch the wrist. Here you can see that he is describing where is the pain also during the mobilization. So when I will record the movement, I will ask him to try to start in a spastic position. So here, with the healthy limb, I will ask him to reproduce the normal position of the spastic limb in order to let him try to go out of this position. So you can see here, he used to have the thumb inside the hand. So I start with this movement with the thumb inside the hand. So global movement in opening the hand. Very slow motion, and we stay in opening position, and we never go back in flexion in order to not stimulate him in flexion muscles. Slow motion and opening. We can speak with him during this first vision in order to see his reaction, his emotion, his feeling, and then you can try to start to mobilize the hand behind the screen. So after small mobilization here, you can see that I'm focusing more on fingers first, and then we can include also step by step the thumb. So I will try to stretch the hand when the movement production is going on the screen for the patient. So when we see here in a global kinetic chain with fingers in and wrist, when the movement is starting, I can start to stretch the hand in order to link the visual guidance to the feeling and to the movement he can feel behind the screen. What is interesting here is the patient is more focusing on hand, which is quite natural on the screen. So they don't put too much attention to the movement mobilization behind the screen, and they didn't feel, you can see here, they didn't feel any pain. He said, no, I have no pain. So with this feedback, I can try to start to mobilize more and more. What is also important here is we didn't go back. So if we are able to win some angles in extension, I hold the position and then try to continue in stretching. So now, what is important also for us is to not say that it's a unique device and you can do everything with. So our objective with several centers and with our network in France, but also in Europe more and more, our objective is really to develop a kind of arm lab concept, because we know that some techniques are more efficient and have some advantages in specific topics. So for example, here on the specific arm lab concept in upper limb motor recovery objective with patient after stroke, we can imagine, we can start first with IVS on mental imagery, body consciousness, movement impulsion, try to improve participation and to engage participation of patients, and for them in motor control. So it's a very good preparation on action planning. Then we can move, for example, on FES stimulation, because patient is able to start the motor command, and the FES will improve the muscles activation. So very good combination, for example, with IVS. And then because you reinforce the power, you will try to put these actions in more functional device or approaches with upper limb robots, and then try to put everything in activity of daily life and global movement. So our goal is really to define, depending the patient pathology and the profile, to define some specific pathway and try to combine techniques, but also approaches. And here, also on upper limb rehabilitation, what is sometimes complicated is the complexity of upper limb function, because you have a lot of degree of freedom, and you have also the specificity of reaching movement and also grasping movement. So both sides is really important for upper limb rehabilitation. Some techniques are really more focusing in reaching. Some other techniques are more focusing on grasping and distal point. And regarding also the recovery profile of your patient from flaccid to low impairment, you will have some techniques more adapted to this kind of patient. So our goal is really to define, a complete, device profile and advantages in order to be able to combine and to define the pathway for patients. So for example, robotics here, it's really interesting for reaching movement from flaccid to mid-moderate impairment. If you have no anti-gravity, if you have no motorized movement, it's more for severe patient, few less impairment, like moderate, low impairment, and other approaches also. Now, just to finish, I would like to present you some data also in our device. So the first proof of concept in IVS was done here in France with some specific patients, so subacute patient, 15 patients, and we have a control group, then a therapeutical group. So the upper left side, we used to have a specific upper limb assessment on distal movement, dexterity, and grasping. So it's divided in 4 sections, and these 4 sections will give you the total score at the end. And what is interesting here is to see that the black part for the therapeutical group is better than the control group in each section. So each section is for very fine movement, gross function, for bimanual activity, and so on. And the final score is the total score of the previous one. So it's interesting to see that we can really improve ability in grasping and dexterity movement. What is also really important here is to see that, excuse me, I have some trouble with my pointer, but you can see on the lower part for the graph here, you have the follow-up for patients. So still black point for the therapeutical group and white point for the control group. First is the inclusion assessment. Then you will have the assessment at the end of the rehabilitation program after 30 sessions and 6 months here after stroke. And 6 months after stroke, you can see that you will have higher improvement. This is the same also here on the box and block test on the right part. You can see the inclusion test and then end of the training after 30 sessions of IVS. So red is the intervention group and blue is the control group. So you will have some improvements, some trend of improvement because it's not significant end of the training. But what is significant is 6 months after the rehabilitation program, we continue to have some improvement in patient. So what is interesting is really to imagine that this program in mirror therapy and mental imagery is also linked with activity of daily life. Here, it's a studies on Eeg measurement. So first part, the left one, is a specific cortical evaluation on the brain on IVS on healthy people. You will have 3 conditions you can see on the upper part of the graph. So a specific condition in observation, specific condition in imagination, and specific condition in execution. And then you will have your results here on the right part. So the observation, imagination here, and execution, you will find also the sum up on the right part in a specific beta rebound analysis. So that means we are measuring activity during movement, and then here we are measuring the action and then the beta rebound. And on the right part, you will have the sum up. And you will have still observation, imagination, and motricity. And T and M is for mirror therapy. So here we will simulate a patient with the right hand affected. But in mirror therapy, because you will use your non-affected side, so the left hand, you can see that in observation, you will have a high cortical activity on the right part of the brain, on imagination too, and in motricity too. You will have bilateral activity. So here, what is interesting is to see that mirror therapy, you will have bilateral activity, or at least you will have higher activity in the non-affected side of the brain. In IVS, so the lower part of the graph, what is interesting is to see that you will produce movement with the non-affected side, and then you will store in your device and let the patient see only the affected side is moving. And here, if you see the potential right affected side, you can see that on IVS, just with observation, you will recruit the cortical area dedicated to motor control here on the left part of the brain. So you will have a specific and lateralized activation in the affected side of your brain just with observation. So this is a really important result, because observation is, in fact, a specific work. On imagination, here you can see that you will have higher activation, and in motricity, you will have a really much higher activation on the affected side. So what is really interesting is to see that IVS followed now the recommendation on brain plasticity stimulation, because you will have a specific and lateralized stimulation on the affected part of the brain. I would like to thank you for your attention, and I remain at your disposal to discuss and to reply to your question. Thank you so much.
Thank you, Davy, for giving such a detailed presentation. Now we'll move on to the Q&A section. If you guys have any questions, feel free to ask or type it out in the comment section. Thank you.
I have a question to Davy, actually. So you mentioned about the comprehensive arm therapy concept to combining the IVS-3 with different modalities. So how about for the non-invasive brain stimulation, let's say TMS and TDCS? So do you recommend people doing that conjunction with the mirror therapy, or they have to do it separately?
You mean some contrast-induced movement therapy?
Yes. No, TMS and TDCS during the...
Oh, TMS and TDCS. So
yes.
I didn't present the result because I don't want to be too long, but we are performing now specific studies where we combine TDCS with IVS stimulation, because the two techniques are really linked and focusing on brain plasticity. So it's really interesting to mix the two techniques in the same time. But sometimes we would like also, for example, to combine with vibration therapy or robotic therapy in the same time. But you have also to consider that sometimes the patient is not able to receive too much information on only one moment. So you have to ask yourself, do we have to do all the techniques in the same time, or maybe to try to create a specific sequence of stimulation? But just to conclude on that part, yes, I think TMS or TDCS, because it's easier to use maybe for patients, TDCS and IVS therapy is very complementary.
Thank you so much.
I didn't check the chat if we have some. No. Okay.
I think if there's no other question from the audience, we can conclude this webinar, and maybe we will leave the contact of David later on in the next email. So if you have any questions afterwards, please feel free to contact us. My colleagues will get back to you shortly about this. And thank you for all the attendance of this audience of this webinar. And we had record this webinar. So shortly afterwards, my colleagues will also share the link of this webinar. Thank you so much.
Thank you so much,
Thank
everybody.
you.
Bye.
Bye-bye. Have a good day.
Bye.
Bye.